Hello, everyone. My name is Evan Lipson, and I am an associate professor at the Johns Hopkins University School of Medicine and the Bloomberg Kimmel Institute for Cancer Immunotherapy here at the Sidney Kimmel Comprehensive Cancer Center. I'm delighted today to be talking to you about the melanoma treatment landscape. Here are my financial relationships to disclose. A couple of objectives today. First, we'd like to discuss the melanoma treatment and research landscapes. That includes standard therapies for patients with advanced melanoma. I'd also like to discuss some of the obstacles to providing benefit to all patients, including those with rare types of melanoma. And I'd like to discuss some promising bright spots on the near-term horizon in the research space in melanoma. Let's begin with some standard therapies for patients with advanced melanoma. Typically, we think about standard therapies in three categories: immunotherapy, mutation directed therapy, and chemotherapy. And today I'd like to concentrate on the first two, immunotherapy and mutation directed therapy. And to begin our discussion today, let's begin by discussing immunotherapy. So I like to think of immune cells that swim around the body as sort of like a fire department. They're looking for things that shouldn't be there. They're looking for viruses. They're looking for infectious agents. They're looking for cancers that are growing that need to be attacked. And in general, immune cells are pretty good about finding things that are foreign and attacking them. And in fact, that's one of the reasons why the human immune system is so well equipped to combat cancer, is because it can recognize an almost infinite number of threats. When cancers grow, when infections appear, the immune system has the capacity to recognize lots of different molecules in various shapes and sizes. The second reason the human immune system is so remarkable is that it can adapt as the threat evolves. And so as cancers develop genetic mutations that change the way the surface of the cancer cells look, the immune system too can evolve right along with it and can track those changes and adapt. And lastly, one aspect of the immune system that's so valuable is that it has memory. And so that means it can provide protection even after therapy has stopped. So for example, when you get a vaccination against an infectious disease, oftentimes with a single shot, you are now protected for many, many years. And the same is often true with cancer immunotherapy. Once the immune system has been activated against a tumor, oftentimes the immune system continues to fight that tumor even after the immune therapy is long since gone. One of the most promising types of immune therapy is called immune checkpoint inhibitors. And if we go back to our fire department analogy for a moment, an immune checkpoint is sort of like hiding a fire hydrant from the fire department team. It makes it difficult for the fire department to put out fires if the fire hydrant is hidden. And so immune checkpoint inhibitors are medicines that prune the bushes, if you will, that take down the barrier so that the firefighting team can clearly see where the fire hydrant is, access the water, and put out the fire. So immune checkpoint therapies sort of pull the brakes off of the immune system. Their names are listed at the bottom of this slide. Pembrolizumab, nivolumab, ipilimumab are some of the names you might have heard. And what I've listed here in this table are some statistics from some clinical trials that have been published in the last few years. Here are the percent of patients with advanced melanoma who are alive at the 5-year mark after having been treated on some of these clinical trials. So as an example, patients treated with pembrolizumab, 43% of those patients were alive at 5 years. Similar numbers with nivolumab, a very similar drug to pembrolizumab. 44% of patients were alive at 5 years. And then if you combine two of these immune checkpoint inhibitors together, ipilimumab and nivolumab, that number is 52% of patients who are alive at the 5-year mark. So as you can see, this therapy is effective for some people but certainly not everybody. And it's the job of clinical researchers to try to increase those numbers, those percent of patients alive at 5 years and beyond, as high as possible. So let's discuss some of the challenges that are associated with activating the human immune system in the ways that I just described. Using those drugs sometimes results in collateral damage, which means that the immune system can cause potentially serious injury to normal parts of the body. So the question then is, can we activate those immune cells that I was talking about in order to attack only the cancer and leave the normal organs alone? So this is sort of like the fire department showing up at somebody's house that's on fire, and in addition to putting out the fire, they also accidentally flood the neighbor's home. And so to keep the stream of water directed only at the house that's on fire, to keep the immune system directed only at the cancer and not at the normal organs, there are clinical trials going on right now to try to direct the immune system's attention only on at the cancerous tumors. One of those trials combines two of the medications I mentioned a moment ago, ipilimumab and nivolumab, and combines it with another antibody called tocilizumab. And tocilizumab is an immune suppressive. It's sort of a director of the immune system that perhaps helps the immune system concentrate only on the cancer and leave the rest of the normal parts of the body alone. Another challenge associated with activating the human immune system is that not all tumors respond in the same way. And so as an example, immunotherapy is much less effective against ocular melanoma, which is sometimes called uveal melanoma. So it turns out that the biology of that tumor, of ocular melanoma, is very different than skin melanoma. And when we use immunotherapy, the same drugs that I just mentioned a few moments ago, it is far less effective in patients with ocular melanoma than it is with skin melanoma. So that's challenging. That leads us into a discussion of some of the promising bright spots, if you will, that are on the near-term horizon. These are clinical trials or investigational drugs that show some promise. I'd like to give you one example. This is a study that's being talked about right now that involved about 700 patients, all of whom had previously untreated advanced melanoma. And these patients were assigned to one of two treatment regimens. They either received nivolumab, which is an anti-PD-1 drug, in combination with a new medication called relatlimab. And relatlimab is a drug that targets an immune molecule called LAG-3. So an anti-PD-1 in combination with an anti-LAG-3 was one of the groups. The other group was assigned to receive nivolumab by itself, so anti-PD-1 as a monotherapy. And these results are just coming out, but what was recently released was that the combination therapy, the nivolumab plus the relatlimab together, controlled tumor growth for a significantly longer period of time than nivolumab alone. So we will learn more in the coming weeks as these data are presented. But this is an example of how combining two immune therapies can oftentimes be more powerful than using one alone. Another immune-based therapy that's on the horizon is called tumor infiltrating lymphocyte therapy. A lymphocyte is a type of immune cell, and it so happens that many lymphocytes infiltrate tumors, meaning that if you took a tumor out of a patient, you would see among all of those cancer cells that they were immune cells hanging out inside the tumor, presumably waiting to be given the go signal to attack what's in front of it. Oftentimes, for whatever reason, lymphocytes are present in the tumor but unable to attack what's in front of it. And so the objective behind these therapies, these TIL therapies, is to take those immune cells hiding out in the tumors and activate them so that they are then able to attack the tumor. So that's basically how this therapy works. The first step is surgical removal of a tumor from a patient. And then Within those tumor, the immune cells are found and extracted within the laboratory, and in the lab they are activated. They're combined with some molecules that create activity in those immune cells such that they're now ready to go and attack tumor. In the coming weeks, in the weeks subsequent to the activation of the tumor cells, the immune cells in the laboratory, the patient then receives a few things. One is chemotherapy, and this is done to sort of wipe the immune system slate clean, so you have a clean slate to work on. Secondly, those activated immune cells I was talking about are then infused into the patient. And then after that, some additional drugs are given to sort of further boost the immune system. And this is a technology that's been experimented with for many, many years now, but is just now sort of coming into the mainstream, if you will. The medicine that is receiving the most attention is called Lithiulusal. And there's a trial that is, it's been recently published, of 66 patients, all of whom had advanced melanoma, all of whom had disease that had progressed after receiving standard immunotherapy and, in some cases, targeted medications, mutation-targeted medications, which I'll talk about in a moment. So all of these patients were previously treated and had disease that progressed through standard therapy. In any case, of these 66 patients, we saw that approximately 80% of them experienced a reduction in tumor size. Sometimes that reduction was quite marked, and other times that reduction was quite small. What you're seeing on the bottom of the slide is called a waterfall plot, and each of those vertical colored lines represents a single patient. If the line goes down, if the line is in a downward direction, that means that the tumors shrank. If the line goes up, that means that that patient's tumors grew. And you can see here that far more lines go down than go up. In fact, 50 patients had tumors that shrank and only 12 patients had tumors that grew. So these results were presented last year, and we are awaiting some additional data. Another thing to understand about these therapies, about immunotherapies generally, is that we are experimenting with when we can use them. So one way that's happening is that we're trying to understand whether we can help prevent the recurrence of high-risk melanoma by using immunotherapy before surgery. So typically, when a patient with melanoma undergoes surgery, sometimes for a larger sized tumor, the risk that the disease will come back is quite high. What is being trialed at the moment is that in patients with melanoma tumors that can be removed surgically, we're administering immunotherapy up front, and we don't know yet which drugs are the best ones to give and for how long they should be administered. But shortly thereafter, those tumors are removed surgically. We don't yet understand whether we can safely decrease the size of the surgery that needs to be done. And then in the post-surgical period, we're trying to understand whether this approach will mean that melanoma tumors will come back less frequently than in patients who just undergo the surgery alone and did not get the immunotherapy. So that's on the horizon as well. All right, so now we'd like to switch gears and talk about mutation-directed therapy as another one of the standard treatments available for patients with advanced melanoma. So what is mutation-directed therapy? Well, every cell in the body has a job to do, and the directions that that cell is supposed to be following is contained in that cell's DNA. DNA is just a collection of molecules that need to be in a specific order to tell the cell exactly what to do. And a mutation, a change in those directions by just a single letter sometimes is all it takes to substantially change what the direction the cancer, what direction the cell is receiving. So as you can see on the right, it doesn't take much to turn the word dancer into the word cancer. And that is essentially the signal that the cell is getting. A single mutation can oftentimes mean that a cell is now directed to grow out of control, and that is what forms a cancerous tumor. So what are the mutation-directed therapies that are out there? Well, oftentimes the most common mutation that is searched for in a melanoma is called BRAF, and there are 3 combinations that are approved by the FDA. They're listed on the right. Dabrafenib and trametinib is one. Vemurafenib and cobimetinib is another. That more recently has been combined with an immune therapy called atezolizumab, and then encorafenib and binimetinib is the third. And so we typically use those medications standardly in patients whose melanoma harbors a mutation in BRAF. Another frequent mutant we see is NRAS. NRAS is a gene that we see is mutant in about 20% of melanomas. And in some patients, we use a medication called binimetinib, which is sometimes effective in stopping tumor growth. And then in other melanomas, another gene called c-KIT is mutant, and there we use a drug called imatinib for those patients oftentimes. So getting back to the likelihood of success in patients who have a BRAF mutation, for example, if you look at the percent of patients with advanced melanoma who are alive at 5 years after receiving mutation-directed therapy, one combination called dabrafenib and trametinib results in 34% of patients alive at 5 years. Another one, vemurafenib and cobimetinib, is a 39% rate of survival at 5 years. And then we're still waiting on the data at 5 years from the third combination, encorafenib and binimetinib. The trials were all a little bit different, but on balance, each combination appears to be approximately equivalent in terms of efficacy. So what are some of the challenges associated with mutation-directed therapy? Well, for starters, targeting a mutation is often just a temporary fix. And by temporary, I mean approximately 9 months, sometimes shorter, sometimes longer. Having said that, in some patients, for reasons that are not yet entirely clear, the responses last for several years. But that is generally the exception and not the rule. Another challenge is that in some cancers, we cannot identify a mutation that is responsible for the tumor growth, and so therefore we don't know what mutation we should be targeting. In other tumors, we can identify a mutation, but we cannot target it. We don't have a medicine, a molecule, a drug that can get in there and stop that mutant molecule from causing the cell to divide out of control. All this to say that a lot of scientific and clinical work is currently underway to address each of these issues. So now I'd like to talk a little bit about what is next. And broadly, what is next is widening the net. And by widening the net, I mean discovering effective therapies for patients that are not yet deriving benefit from the medicines that we have just talked about. So one of those patient populations are those people who were previously excluded from clinical trial participation. So for example, in the immune therapy space, with immunotherapy trials, oftentimes patients with autoimmune diseases, patients whose immune systems were not quite right to begin with, or patients who are organ transplant recipients, for example, kidney transplant recipients or liver transplant recipients, were excluded from clinical trials. So this is an issue because those patients oftentimes wind up with skin cancers that are aggressive and need therapy, but we don't really understand how best to use the medications because these patients have been excluded from clinical trials. So we have a clinical trial that looks at one patient population. These are kidney transplant recipients. Here is a CT scan from a 57-year-old kidney transplant recipient who had metastatic skin cancer. All those yellow arrows are pointing to tumors growing in this patient's lungs prior to giving her therapy. And as you can see on the right side of the slide, at 8 months, all of those tumors have gone away with the possible exception of that one little guy just at the bottom there. When this patient received immunotherapy, those tumors, as you can see, disappeared, but her transplanted kidney was rejected by her immune system. We turned her immune system on so vigorously that it caused rejection of her transplanted kidney, and she had to go back on dialysis. The good news is that she was had no evidence of cancer at about 4 years and has since received a new kidney, so is doing fine. But this is just an illustration of how difficult it is to treat patients like this who have immune differences. So this nationwide clinical trial that I'm leading is designed to find a safe and effective immunotherapy regimen against cancers that arise in kidney transplant recipients. What else is next when we're talking about widening the net? Well, we need to discover effective therapies for patients who have rare types of melanoma. And perhaps the most dramatic example of this are patients who have uveal or ocular melanoma. So this is melanoma that starts in the back of the eye. Unfortunately, this particular tumor type often does not respond very well to immunotherapy. So the 5-year survival rates that we talked about at the beginning of the lecture don't come anywhere close. The 5-year survival rates in ocular melanoma are not nearly as good as what we just talked about before. There are mutations in ocular melanoma, but we have not yet been able to effectively target them. And so for that reason, we highly encourage patients to engage with clinical trials when possible. One of those clinical trials has recently shown some success. It is testing a medication called tebentafusp. And tebentafusp is a novel medication that helps immune cells direct their activity toward uveal melanoma cells. They kind of bring the immune cells together with the melanoma cells and help the immune cell attack the melanoma. This has been submitted to the FDA, to the Food and Drug Administration, and the FDA granted what is called Breakthrough Therapy Designation. So Breakthrough Therapy Designation means that a drug that treats a serious or life-threatening condition has demonstrated preliminary clinical evidence and a substantial improvement over other available therapies. And so because this is such a difficult to treat disease, and because there was some benefit seen here using this new medication, the FDA granted Breakthrough Therapy Designation. There is a large clinical trial that is about to be reported in the next week or so that is comparing tebentafusp with standard therapy in patients with metastatic uveal melanoma. And so we should know more about this study and what the results are next week. So I thank you for your attention.